Hi, I'm Dr. Ralph Weike, Medical Program Director for Whatcom County EMS, and thanks for taking a moment to review these protocol updates for 2025. These updates have been a collaborative effort among the EMS physicians as well as the EMS providers and your leadership. We've listened to you and we've tried to incorporate some of your suggestions, such as you wanted specific doses instead of ranges, and that's been changed whenever possible. But we've also incorporated some major changes, which include things such as dual sequence external defibrillation in our high performance CPR. And we've also changed our spinal immobilization algorithm. But it's important for me that you understand that these protocols are not merely guidelines, but they are your ticket to ride. It is what authorizes you to do the important work that you do. And that also means that if there's something, even if it makes sense to you, but is not in the protocol, that you should consult online medical control or discuss it with your supervising physician later. It's through this iterative process that we all learn. And this is Oreo, and we want to thank you for your professionalism and the good work that you do and the impact that you make on our community. It makes me proud to be part of the team. So thanks for what you do. Bye-bye.
Welcome to the 2025 Whatcom County Protocol video. I am Captain Howry, Fighter 617, and part of the Protocol Committee.
My name is Cole Crockett. I'm a firefighter paramedic with the Bellingham Fire Department, also part of your Protocol Committee.
Hi, Christopher Carlton. I'm Fire Chief up in Point Roberts, District 5, and also on the street with everybody as a firefighter paramedic with Whatcom 7 in Ferndale. I think we want to expand on some things real quick regarding the Protocol Committee. This has been a work in progress for the better part, if not over, the last year. And we've had numerous people involved, not just here, but in the other videos that you're going to be watching as well. And then we definitely want to give thanks to the physicians that took a lot of time to sit down with us, listen to the comments coming from the field, and making sure that this was a good rendition of what we want to provide to the citizens of our communities. What do you guys think?
I agree. There's been a big help from everybody involved. We've been able to collectively come together and create a protocol that has been beneficial for everybody.
I think this represents an update in not just Whatcom County, but brings us in alignment with some national trends. We've had a solid foundation established through Whatcom County Medic 1 with Dr. Wayne, and now with the new doctors, Weike, McNeely, and Welch at the helm. I think this brings us forward into the future.
All right, let's get into it.
We'll start with an overview of major changes that you can follow along with at the beginning of the protocol, and then we'll highlight some specific protocols more in detail at the end. First off, the rescue pump has been removed from the protocols, so if anyone was still using that, feel free to remove it now. The ALS indicator has been added, that is head injury with new paralysis, focal weakness, or numbness. We've also removed an ALS indicator being hypertension without symptoms.
Non-EMS transports, you don't have the requirement anymore of having to call the charge nurse at the hospital if someone decides not to go by ambulance transport, so that's been removed. We have a refusal of care, revised refusal, medical capacity language, which is going to be a big part of what we are going to be discussing here after a while. And then we have the initiation and termination resuscitation, also known as TOR, T-O-R. We've added some language within the protocols for that.
In an effort to expedite critical patient care, we've updated the helicopter transport section, added criteria, destinations, and activations. We've also added some numbers to the crosses hotline section, so if there are additional numbers out there that you can provide the community. The SALT section, we also removed expectant section, which is the gray area of the triage.
You may notice that some sections throughout the protocol have been grouped for greater continuity and similar pathophysiologies. Cardiac is one of them. It won't be interrupted by burns, for example. In the arrhythmia protocol, there was a line mentioning synchronized cardioversion. That's been removed, and it now has its own page with more specific instructions. And the bradycardia algorithm has been simplified, as well as the tachycardia algorithm. Those are both based on identifying rhythms from the EKG and then treating appropriately.
The tachycardia algorithm, amiodarone's been removed from the wide irregular pathway. For clarification, the pediatric bradycardia doses have been removed, and there's more prioritization on pacing versus any type of chemical therapy in the pediatric bradycardic algorithm. And then we also have a change to the ventricular fibrillation VTAC flow chart, and asystole and PEA flow chart are both new.
There's a completely new section for dual sequential external defibrillation. We'll be going into more detail of that after this. We've also introduced the occlusive myocardial infarction moniker, OMI. It replaces STEMI. And there's also a cold-related condition section, hypothermia-induced cardiac arrest has been updated.
Under hypoglycemia, there used to be some disagreement between when to treat with glucose, and that's been simplified to just less than 70 milligrams per deciliter for adults. A new protocol has been created for opiate withdrawal, and that will tie into a medication that you'll hear in a minute. And the carbon monoxide exposure algorithm has been simplified and reduced. Some redundancies have been removed.
In the pediatric medical information area of the protocols, we've added a high-risk medical criteria and the mandatory transports for pediatrics. Respiratory section, we have now replaces shortness of breath, regroups CHF and pulmonary edema, and then pediatric respiratory distress and CHF treatment. We also have some changes to the cardiogenic shock area.
The pediatric group epiglottis section has been updated with epi prioritized over albuterol. The stroke section has also been updated to include LAMB score as well as BFAS and related definitions. The syncope, we also added reference notes to make ease of identifying.
The trauma section is another one of those sections that's been grouped together, and you'll see some major changes there. The big one is being the traumatic arrest protocol. We'll dive into this in more detail momentarily. The quick touch is that we'll use the MARCH acronym taken from the military as a general approach to these, and you'll see the accompanying flowcharts throughout the document.
Trauma arrest protocols new, and that's going to be a section that we're going to take some time on with you today to review. Pediatric trauma triage flowchart is new for younger generational children. Procedures, we did remove pericardocentesis.
CPAP has been updated for BLS use, including pulmonary fibrosis caution as well as pneumonia identifiers. Endotracheal intubation has also been updated to clarify procedures, RSI, DSI, and meds. And synchronized cardioversion has a new section altogether.
Changes for the medications include adding haloperidol. This will be a new medication for community paramedics to add to their pharmacy. And albuterol, we've clarified that within Whatcom County, we do not need a patient prescription for BLS to use an albuterol nebulizer.
The epi injection procedure, we moved that to the BLS administration of meds. Abdominal complaints, nitrous oxides can now be used by BLS practitioners for that type of presentation. And we've made some changes to ketamine, the dosing, and also removed the indication for bronchospasm.
Changes have been made to nebulized epi, now using intramuscular epi at 1 to 1,000 instead of 1 to 10,000, which was a much higher dose. Amiodarone indicator removed from wide irregular tachycardia was changed, and buprenorphine, also known as Suboxone, is new, and there'll be more details, another video on that you can access on the EMS site.
Droperidol has been added as a new medication. That'll be a frontline medication that we see in the future. And sodium bicarbonate has been adjusted to provide more consistent dosing. Through that overview with us, now we're going to dive into about a half a dozen special topics in more detail so we get a better understanding of the major changes that we've included. That'll be refusal of care and medical capacity, dual sequential external defibrillation, occlusive myocardial MI, occlusive MI, trauma arrest and protocols with some touch on medical arrest as well, and abdominal complaints and the use of nitrous oxide by BLS providers. So with refusal of care, really what we're talking about is a patient's decision-making capacity. And as you read through this document, you'll see that it is a lengthy section. It's about 5 pages long, and that's because we're emphasizing the importance of respecting a person's autonomy and their decision-making ability, while also trying to give them the best level of care that we can. And sometimes that means that they may have to do something they don't want to do. So we're going to work through the process of determining that. This isn't a massive change from the old way of doing it, but in general, this gives us more legal ground to stand on if we're ever called to court for why we left someone at home, or if we forced someone to go with us despite their expressed refusal. So there are some cases right up front where people do have to be transported. These are consistent with past practice. These are patients who have expressed suicidal or homicidal ideation, minors with possible emergencies, in some cases where parents are refusing. We have to take those minors. And in patients that lack capacity. We'll get into that capacity concept in just a minute. Most of the time, we go for patients who are able to express their consent or refusal. There are some times where patients can't, and in those cases, there is a hierarchy of people, usually family members, sometimes coaches, teachers, people who can act in loco parentis is the legal term, and make decisions or give consent for those people. And that's listed in the protocol. There are some special situations, again, minors being one, patients with mental health or psychiatric emergencies, patients with intoxication, transient capacity such as hypoglycemia or, for example, opioid overdose where they're in and out of consciousness, as well as the elderly and patients at end of life. These all have some special considerations. Take the time to read through here and understand that we are trying to respect their decision-making capacity while give them the best option, best course of care as their. We do have a checklist. It's going to start out reading a lot like built-out sample history. That's to show and demonstrate that we're putting in the effort to dig into our patients' past, their conditions, and show that we've been as thorough as we can, largely so that we can provide best care to them, but also to provide that protection to us as providers if we're ever called. Once we've assessed a patient and we've gone through their list of options and given them our recommendations, then it's up to them if they want to come with us or if they want to refuse. If they can show decision-making capacity, then they have every right to refuse, and we're not going to force people. However, if there are times where they don't meet the criteria for capacity, that's when we have to step in and involve law enforcement and or medical control. So there's 4 pillars to decision-making capacity. I'll give you a sort of a brief overview and my understanding of it, and by all means, read through this, ask questions, talk about this amongst your crews, and this will continue to be something that we build on both here within our own system and on a national level. There are changes moving forward. The 4 pillars of a patient's decision-making capacity include understanding, appreciation, reasoning, and communication. Not immediately, but we are working towards a checklist that should be able to pop up in our documentation software so that we can just ask a list of questions rather than hope that we're grabbing abstract thoughts from the air. We want to be able to document these 4 pillars. Understanding would be asking a patient to describe the problem they're having now and what options we're proposing for their help. And appreciation would be having the patient again describe the options we've presented them and allowing them to accept or decline treatment. Or reasoning is shown by them giving the factors that are important to them, expressing why they do or they don't want to come with us, and whether or not they even trust us in the first place. And then a communication factor, are they able to express to us and communicate with us that understanding of the situation, the appreciation of its severity, their reasoning for wanting to refuse despite our best recommendations, and being able to communicate all that. Like I said before, if a patient can meet all 4 of those pillars and answer those questions, then they can refuse and we can allow them. But if they can't meet those, then they legally do not have decision-making capacity, and so we need to involve law enforcement and maybe med control. If an officer isn't willing to help take custody of a patient, that's also an indication to contact medical control, and that doctor can provide direction to the officer, and that liability can be shared there. So that's a brief overview of decision-making capacity. With all of this, as always, document thoroughly, and that'll keep us covered while providing the best level of care to the patient. The next topic we'll cover is dual sequential external defibrillation. The next topic we'll discuss is dual sequential external defibrillation and how it relates to vector change. In any case of putting defibrillation pads on a patient, we want to start with the anterior-posterior positioning. This goes for cardiac arrest, transcutaneous pacing, and synchronized cardioversion. Indications for dual sequential external defibrillation include the fourth consecutive shock in cases of refractory VFib, VTAC, shockable rhythms. So after 3 consecutive shocks, we can move towards an external defibrillation approach. It requires 2 monitors, and the second set of pads would go in the anterior lateral positions. It involves charging both monitors to the same energy setting, and then in rapid succession, defibrillating both of those monitors, one and then the other, with less than a second pause between them. If we don't have 2 monitors, we can still use a vector change, which also involves putting additional patches on in the anterior and lateral position, and that can be done with both the monitor and an AED. When we're putting pads on a patient, we need to make sure that they're not touching each other so they don't arc. They need to be out of the way of the Lucas suction cup and also away from a patient's implanted cardiac defibrillator or pacemaker. The next section we'll talk about is occlusive myocardial infarction.
The next protocol we'll dive into is the occlusive myocardial infarction, also known as the OMI, which replaces the traditional STEMI. This is more indicative to what is going on within the patient. The Sarbosa criteria identifies within patients with left bundle branch block or a paced rhythm if they have an OMI present. The protocol includes a schematic which shows the rhythm strip that you'll be looking for. Treatment for these patients are similar to what you would do for a normal cardiac event. BLS providers can provide aspirin and assist with nitroglycerin. The ALS providers can provide atorvastatin. The symptoms and the way the patient presents are similar to a traditional cardiac arrest, with one exception. Sweating, nausea, vomiting, pain radiating to the shoulder or jaw, but traditionally now it's the right shoulder. This always increases with a preset probability that the patient is having chest pain due to ischemia. In women, diabetics, and elderly patients, the chest pain may be completely different.
Hi, it's Dr. Ralph Weike again, and I wanted to comment on one of the other changes to our protocol related to our spinal motion restriction protocol. And so the main change there is that we are going to go back to the use of hard cervical collars instead of our horse collars that we've been traditionally using. And the reason for this change is to be more consistent with the recommendations of our societies and organizations that recommend the use of hard collars. One such organization is our National Association of EMS Physicians, and their joint position statement says specifically that an appropriately sized cervical collar is a critical component of spinal motion restriction and should be used to limit movement of the cervical spine whenever spinal motion restriction is employed. So we're going to use hard cervical collars. We're going to continue to use vacuum mattresses in the same manner that we have before. So I recognize this represents a significant change in patient care, but I believe that this represents the best current evidence-based practice for the care of our trauma patients.
Hi everybody. So at this time we're going to talk about traumatic cardiac arrest. I'll also be referencing some medical cardiac arrest as well, but this topic is really covering traumatic. So to start off, air medical is going to start being utilized more within a system approach from this point forward. So I believe this is going to benefit a lot more patients in our future and provide them the level of care that's necessary to save more lives. So traumatic cardiac arrest, obviously when we show up, we're looking for the DOAs. So please review that section in the protocol. Something that we're going to be changing both in the traumatic cardiac arrest and also the medical cardiac arrest would be someone that may be in PEA due to blunt trauma or in a medical cardiac arrest with a PEA that is narrow and has rates greater than 40 beats per minute. Those patients are likely going to be being transported for further care at St. Joseph's Hospital. So a new acronym that was placed in the traumatic cardiac arrest protocol is called MARCH, M-A-R-C-H. So the M stands for major hemorrhage. We're going to be controlling hemorrhage more aggressively with tourniquets, by packing wounds, etc. The A stands for airway. We want to make sure that the airway is properly positioned for BVM usage, for iGel usage. And if we do have some type of an obstruction in the airway, then we need to go to endotracheal intubation. The R stands for respirations. We want to be looking for a tension pneumo and doing proper decompression of the chest wall regarding the second intercostal space or the fourth and fifth intercostal space. The C is for circulation. We're going to be using blood when available, and the Air Medical will have that option for us. And when we don't have blood available and we have blunt trauma, we're going to be infusing 1 liter of fluid. If we have ROSC associated with this traumatic cardiac arrest, we're going to be looking at titrating blood pressures to 90 for primary hemorrhagic shock and also 135 for a potential TBI. So when it comes to a BLS approach, and the last part of this would be hypothermia, someone that's hypothermic, someone that's had a head injury, or somebody that may be hypoglycemic. When we've had ROSC achieved, we want to make sure that we are pre-warming the rig, that we're removing wet clothing, we're considering that it could be a TBI, and we want to make sure that we check for the glucose on those patients. Again, going back to the PEA, this is probably a big change for us. And we're looking for PEAs that are greater than 40 beats per minute, that are narrow, complex, both in traumatic and also medical cardiac arrests, and potentially transporting those patients when they're presenting to us in that fashion. There has been studies that have shown that we do have cardiac function in a PEA, but we're just unable to determine that in the pre-hospital setting. So that's where the guidance is leading us. We want to make sure that we're dealing with pregnancy patients appropriately. If somebody is greater than 24 weeks or the fundus is present, those patients are considered DOA on scene. We would probably go ahead and work that mother and transport them to the hospital if it's less than 15 or 20 minutes of a transport. And again, that's where Air Medical will come into play and benefit some of these patients a lot more in our protocols. So just make sure that you're doing the best you can. Follow high performance CPR guidelines for traumatic cardiac arrest as well. Identify the blunt and penetrating traumas. If we have somebody that is in VTAC or pulsus VTAC or VFib and it's a blunt arrest, we're actually treating them per the medical arrest protocol. If we have somebody that has penetrating trauma with PEA or asystole, then we're looking for that rate. So is it less than 40 beats per minute or is it greater than 40 beats per minute? And is transport time greater than 15 minutes to consider that patient either viable or termination of resuscitation. So that covers traumatic cardiac arrest. The next process that we're going to be discussing is nitrous oxide for BLS responders.
The last protocol we're going to cover is nitrous oxide for BLS providers. Please pay close attention to indications and contraindications as they have changed and they become more detailed. I'd like to review the contraindications as they are decreased level of consciousness, traumatic chest injuries with possible pneumothorax, serious facial injuries with a good seal cannot be obtained, COPD, pregnancy other than delivery in the 3rd trimester, and suspected valve obstruction or perforation. However, BLS providers have been approved to administer nitrous oxide to patients with general abdominal pain. Thank you for watching the video. I'd like to thank my partners, Chief Carlton and Paramedic Crockett. Please review these updates. They're meant to improve care, safety, and your ability to make sound decisions. Know your medications, know your tour guidelines, and use that checklist. Thanks for watching. Send comments to protocol update at co.whatcom.wa.us. Stay sharp and stay safe out there.
Thanks, everyone.